Hello, welcome back to my channel, welcome back to Clinical Psychology Community UK. My name is Holly, welcome, thank you so much for joining us today. So today we're going to go through an introduction to cognitive behavioural therapy, better known as CBT. If you want to know anything else about clinical psychology, hopefully you can find lots of resources on my channel. So click subscribe and you'll get updated when there's a new video. Okay, so let's get straight into it then. So today we are going to look at what is CBT. You might hear it all the time and not know what it means. It's fine, we will cover it. What are some of the key CBT principles? What makes CBT CBT? We're going to look at CBT formulations. That's just a little brief introduction to CBT formulations. And we'll look at some applications of CBT, as well as some of the strengths and limitations. So let's get started. What is CBT? It's cognitive, it's behavioural, and it's therapy. Is the easy version. So cognitive, we mean sort of thoughts, the way that we think about things, the way that we perceive things. Could be to do with sort of distorted thinking patterns. That's like cognitive is what we think. Mental processes is what we mean by cognitive. In terms of behavioural, sort of does what it says on the tin. It's behaviours, things that we do to keep ourselves safe. So safety behaviours, which we'll cover a little bit later on. And therapy. So it's a talking intervention. It is short term, it is active, and it's collaborative broadly. So some of the history of CBT, I'm not going to go too into it. There's lots and lots of information out there on CBT if you are interested in the full history. But essentially, it has two main influences. Modern CBT, what we know now to be CBT. So behaviour therapy was developed by lots of different psychologists in the 1950s and 1960s, and it was in response to Freud's psychoanalysis, and particularly the lack of evidence to support its theory and its effectiveness. So there was a counter argument, if you like, or a counter theory was, well, let's think about behaviours that people do. So the main theory is what's going on inside someone's mind is not observable. And therefore it's not amenable to scientific study, but behavior is observable. You can see what actions people take, you can see it, so therefore you can kind of measure it, you can observe it. And particularly this is focusing on responses to stimuli, so responses to things around us. The task of behavioural therapy was to establish a new non-fearful response to a stimulus. So something like if someone has social anxiety and is nervous about going out and seeing other people, that is the stimulus, if you like, is other people. And behaviour therapy sought to change that behaviour and that response to that stimuli. And it was also much shorter than Freud's psychoanalysis, which was a hugely dominant theory at the time. Psychoanalysis could be months or years even of going for regular therapy. And this behaviour therapy was sort of 6 to 12 sessions. So it kind of made sense for a lot of people. And the other dominant theory behind CBT is the cognitive therapy, which suggests that mental processes, things like thoughts, beliefs, perception, the way that we view things, can't be ignored. We can't purely have a behavioural way of looking at things, and actually we need to incorporate these mental processes into this behaviour therapy. And after lots and lots of work, I'm simplifying the history, CBT was born. So what are the key principles? Well, the key principles of CBT, the cognitive principle, that's things that go on inside our mind will affect the way that we feel, the way that we behave, and the way that we experience the world. Behavioural, so our behaviours will also impact on the way that we think and the way that we feel about things. Interacting systems, I'll come on to that. Here and now. Continuum and empirical. So points 1 to 2 are fairly self-explanatory, but we will cover them a little bit, and points 3 to 6 we will cover in a bit more detail. But the other inherent characteristics of CBT is that the therapeutic alliance or the therapeutic relationship is really, really important, and that it's collaborative, and the therapist takes on the role of sort of helping the individual but kind of become their own therapist, and it's a journey of guided discovery. So the therapist will ask open questions that will encourage the individual to sort of think differently about things, and eventually hopefully be their own therapist, is sort of the idea. But the CBT emphasizes the idea that the therapist and the individual are on an equal playing field, same level. The person, the individual, is an expert in themselves, and the therapist is an expert in CBT. So they can work together to solve or to fix or to, make better in some way this problem that they're working on. So that's sort of the basics of CBT. Looking at the cognitive principle then, so people's emotional reactions and behaviour are strongly influenced by their cognitions, their thoughts, their beliefs, their perception of the world, the way that they think about things. Essentially, our cognitive function tends to give meaning to our lives. It's our interpretation of events that we go through, our perception of things that happen to us, our memories, our thoughts, and our beliefs. And we have different levels of cognition, is what CBT posits. So on the surface, you've got negative automatic thoughts. So this could be, let's say for social anxiety, if that person walks into a room with lots of other people there, they might automatically think, everyone's looking at me, everything I feared is now coming true, those sorts of things. And they are, you are an embarrassing person, or whatever the thought is, but it's negative and it's automatic. And that is something that that CBT suggests is common among people. Then you have dysfunctional assumptions. So these are assumptions that we make about the world that actually aren't that helpful to us. And then on the deepest level, you have core beliefs. So these are fundamental things that we believe. It could be about ourselves or about the world. For example, the world is unfair. That could be a core belief that people have, and therefore everything they experience, because they believe that the world is unfair to them, or they are at a disadvantage. For example, this is just one, example. Then everything that they see is disadvantaging them. It's that sort of thing. So the idea is that these negative automatic thoughts are very specific, they are accessible, and they're easier to change. And then going down, dysfunctional assumptions and core beliefs are sort of more general things. They're less accessible and far more difficult to change. But that's sort of the idea of different levels of cognition, if you like. And the idea behind CBT is that different types of problems have characteristic cognitive styles. So let's take depression, for example. The idea is that there's a negative triad. So let's say that there's a negative bias. So you have negative views of oneself, the world in general, and the future. So yourself, the world in general, your future. That's the triad. So that's the kind of idea behind, that's the CBT view of depression. So for anxiety disorders, a lot of the time there's a bias towards an overestimation of threat. So in different anxiety disorders, it can present kind of differently. Let's say panic is more like a catastrophic misinterpretation of harmless symptoms, as indicating some imminent disaster. So in panic, when someone's heart starts to go, or they're having a panic attack, it feels like they're having a heart attack. That's what we think a heart attack feels like, and they get more panicked. It's absolutely the worst thing ever. But that's all because they are misinterpreting their heart beating fast for having a heart attack, and it gets worse and worse and worse. So that kind of shows the idea that your thoughts can affect your body, your behavior, the way you feel, that sort of thing. Similarly, like in health anxiety, which has kind of, I guess, become more common in 2020 with COVID and things like that, there's a misinterpretation of, harmless physical symptoms as being problematic, or indicative of some sort of illness. So let's say I've got pain in my stomach, which is common for lots of people. Let's say I've got pain in my stomach and I think, oh my goodness, if I've got health anxiety, I might think, it's stomach cancer. I know it. Every piece of information I read is going to tell me that I've got stomach cancer. And now I know, I can feel it. The tumors grow, all of that sort of thing. But the idea is that actually it could just be trapped wind, or it could be a time of the month for us ladies. It could be lots of different things, but that's what health anxiety does, is it overestimates the idea that there's a threat to me, basically. Those are a couple of different cognitive sort of styles, but that's I hope that explains the cognitive theory sort of behind CBT a little bit more. Thinking about the behavioural side of things then, the idea is that people's behaviour is crucial in maintaining or changing their psychological states. So, for example, if I were to constantly avoid something, it only makes it worse in my head. So I'm going to be honest with you all. I don't like spiders. My fiance doesn't like spiders either, but unfortunately he has to deal with them. I know, I feel awful for him. I'm a terrible person, but anyway, I can't deal with spiders. If I see a spider, I run out of the room at 100 miles an hour. I completely avoid the situation. I can't cope with it. But what is that actually teaching me? It's teaching me that every single time I see a spider, my anxiety goes through the roof. And anxiety will go down. It will reduce. That's what anxiety does. You will not stay in that panicked mode forever. I'm not sitting with the situation long enough to wait for it to decrease. I'm not learning that actually there is no threat. We don't live in Australia. I live in the UK. Spiders, if they bite me, they're not poisonous. What's the worst thing that's actually going to happen? But I have that fear of them completely. But I'm constantly avoiding it. That's sort of the idea. And avoidance is a very common safety behaviour because we can be kept safe from the threat that we perceive. So that's kind of the idea behind the behavioural side of things. Now we come to the interacting systems part, the interacting systems principle. So if you've ever learned anything about CBT, you will know what this is. This is, some people call it the hot cross bun. I wouldn't say that was a particularly professional term, but it's definitely, people know what this means by the hot cross bun. So the idea is that your thoughts will interact with your emotions and your behavior and your physical sensations, and it will impact on all of these things. Each of those will interact with the other. So let's go around. So let's say my first thought in the morning might be, I'm really nervous because I've got to do a presentation today. Okay, well, if that's my first thought, what does that then lead me to feel? Well, that leads me to feel anxious, a little bit fearful, a little bit worried. Well, what does that do to my physical sensations? Well, usually for me, it manifests really physically. So my heart will start beating. I'll start to feel a little bit breathless, and I'll need to get my breathing under control. I might start to sweat. While I constantly think, actually, this is a really stressful situation, and it gets worse and worse. So what's my behavior? Well, you've got choices. My behavior might be to get my breathing under control. As I said, it might be to do some breathing exercises, to take a deep breath and slow down. Or it could be to distract myself. It could be to get up out of bed, to go and have a shower, to make myself a nice coffee. It could be anything. But I hope that example kind of shows the idea behind it, is that our thoughts, emotions, physical sensations, and behavior all interact with each other and affect each other. It doesn't always have to be in a problematic way, though, either. It could be, so recently I had my birthday, which was really nice. I managed to see my family, which was just lovely. So I thought then, the next day I was feeling really happy and satisfied and content and loved. So I might think, that was a really nice birthday. I really enjoyed that. So the emotion might be relief. It could be satisfaction, happiness. And then physically, I might feel really relaxed because of that. I might just have lots of energy because I feel so happy. I might want to go out and do things. As my behaviour, I might think, actually, it would be really nice to be able to go out and enjoy this, to go on a really nice long walk. So it doesn't always have to be negative. But when we're working in mental health, a lot of the time we are quite problem focused. We're focused on what the issues are. And that certainly is true in CBT as well. But just to give you a little bit of balance there. CBT basically helps us identify how the problem is maintained, how the issue, or what the distressing feature of whatever's going on, how it's maintained. So that's kind of where the formulation comes in, but we'll get to that, don't you worry. So thinking about the here and now, this principle basically is the main focus of CBT, looks at what is happening right now for that person. Oh, sorry, 1 second. There we go. Looks at what's happening right now for the person. What is causing or maintaining the problem right now? It doesn't really spend too much time thinking about lots of historical trauma or difficult experiences. It might, when you're assessing someone for CBT, you might talk a little bit about their history, what they've experienced, what they've gone through, just so you're sort of aware. But it doesn't spend a lot of time unpicking lots of difficult early experiences, kind of like the psychodynamic and psychoanalytic approach will go quite heavily into that. So what you're looking at is what's happening right now, what is distressing you right now, what can we do to change things right now, what are the resources you have available to you right now to make some changes, that sort of thing. I hope that explains the here and now principle. Moving on to the continuum principle then. This is probably my favourite principle. When I was learning about CBT during my masters, we did like a module on it, going through all of the different principles and things. What I really liked, I've never heard of this being explicitly like central to a psychotherapy model. I think it kind of is like inherently there in lots of models, but it's like makes it really clear, so I quite like that. The idea is that mental health issues arise from exaggerated or extreme versions of normal processes rather than due to pathological states. So the idea here is that anxiety, for example, is normal. It's a normal part of life. As humans, we're animals, right? We evolved and we relied on that anxiety response when there was a threat to us. When we were animals, when we were evolving, when there was a threat, we fought, we fled, or we froze. We had that anxiety response. It was absolutely essential to us. Now modern humanity, we don't need that as much. We don't have the same thing, but it's so inherently built into us that it can easily become problematic. And it becomes problematic when it starts to affect, your functioning, or, for example, becoming anxious in non-life-threatening situations, or perceiving that there's a threat when actually there isn't. For example, let's go back to social anxiety. I'm very social anxiety heavy today, apologies. Social anxiety is normal, but if your anxiety stops you from engaging in social situations and it causes you significant distress while you're in those situations, this has become problematic. It's not, it's now an exaggerated form of that anxiety. So that's why I quite like this, because it suggests that actually anxiety is not necessarily like a bad thing, or depression is not necessarily like a weird pathological disorder. It's actually something, you're responding to something that's happened to you, and that's okay. So I quite like that. Mental health issues can happen to anyone, including therapists and psychologists and mental health professionals and social workers, and any professional. Mental health issues happen to us all, and it's okay. But that's the idea, is that, mental health issues are a common part of life, and that they arise from, normal processes. It's not something alien. Thinking about the last principle then, the empirical principle, we should rigorously evaluate theories and base interventions on the scientific evidence base. That's the idea. There are some reasons for that. So ethically, we can be confident in that approach, is the idea, because it's evidence-based. There is evidence behind us saying that this has been used with this population and it is effective. So we're not trialing something out on someone that might not be effective and might cause them any more harm, is the idea. So ethically, it's all right. Again, economically, as we all know, in mental health, the funding is difficult, and basing it on the evidence and the rigorous evaluation of it, we can make sure that mental health resources that are really limited are allocated in the best way to bring about the most benefit. And the thing is, CBT has actually remained relatively unchanged since its conception, but it's been tested and is considered to be the best evidence-based psychotherapeutic model. For example, in the UK, if you go on to clinical psychology training to become a clinical psychologist, it's a very rigorous program, and you have the opportunity, depending on the course, to look at various psychotherapeutic models, whatever sort of resonates with you. But CBT is you will absolutely be trained in CBT, because that is what all of the courses are focused on, because it's the most evidence-based. Make of that what you will. We'll come to the critique in a bit. Thinking then about the assessment phase. So CBT assessment, I mean, it kind of falls down to lots of other types of assessment, really. It's asking questions of the person to obtain relevant information. That could be their history, you know, any relevant history, family history. It could be history with your service, any previous input from anybody. It could be how long they've been dealing with this issue. Anything like that, really. Any information that is helpful. And it can be seen as a phase. It's not necessarily, right, I've booked in this assessment and we will do it for an hour and we will be done afterwards and I'll know everything about you. Well, kind of, when you're doing CBT, you're kind of constantly assessing. I think you are doing any mental health intervention. You're kind of constantly assessing and reformulating in your head. But yeah, it can be seen as a phase. And the assessment contributes to the formulation. So, as we know, psychologists work under the framework, assessment, formulation, intervention, and evaluation, audit afterwards. But assessment, formulation, intervention, those are sort of the key, that's the key framework for anyone that's interested in clinical psychology. Know about that framework. And the idea is that the assessment is the gathering information stage and the formulation is sort of putting that information together. So let's go on to the formulation then. Well, there are some key features of a formulation. The idea is that you are sort of mapping out the issue, what's going on, how everything's being maintained. So some of the key features then, you need a description of the current problem or problems that you're trying to look at. You need sort of what is the problem. You need an account of how and why these problems might have developed. So an account, it could just be, you know, asking the client, so where do you think that some of these issues started to develop? Where do you think some of these issues came from? So then you have an account, and you can pick out some relevant information, things that seem significant to you. And then basically a formulation is an analysis or a mapping of the key maintaining processes hypothesized to keep the problems going. So what is the problem? How did it sort of develop? Like, where did it come from? Is there any trigger points to it? And what maintains it? What keeps that problem going? Because to get to CBT, you're either going private, which you can get a CBT therapist and probably start the same day, if depending on their diaries. But if you're going, through publicly funded places, you will most likely have gone through a stepped care model, which means you would have done lots of other stuff before getting to therapy, and there's usually a very long waiting list for their individual therapy. So by the time you get to that, you kind of it depends. I mean, it depends what preparatory work is being done, really. But the idea is that a formulation is collaborative in CBT, and it acts as a bridge between the therapist and the individual. It's a shared understanding of the problems. If the client's not happy with something that's on the formulation, you'd hope that they would be able to raise that and say, actually, I'm not sure about this. This doesn't feel right. Maybe this, maybe this. And it's an idea of working together to get an idea of what the issue is and what maintains it. And it also can act as a bit of a guide for therapy. If you've, let's say, you've done your formulation, you're sort of working on some of the issues that were highlighted as a priority, and then you think, okay, so how you're feeling better about the priority, should we go on to the sort of secondary problem? You can use it as a sort of guide to pick up on bits. So a formulation could look something like this, but there are lots of different ways that you can formulate. It depends on the issues. At a fundamental level, you need to have some consideration of a problem, how our thoughts, emotions, behavior, physical sensations all, interact with each other. But I would add, this is very brief on formulation. There is a fantastic webinar series by Dr. Emily Barney and 2 assistant psychologists, Saba and Rachel. I'll link it in the comments. It's at my.reflectivejournal, and it's fantastic. Those webinars are fantastic. Highly recommend. And I think they're starting to do them again from January. I'm not sure, but they are brilliant. So if you're interested in formulation, then I'll link those videos in the description. But a formulation kind of looks like this. You have a problem. You have the idea that thoughts, emotions, physical sensations, and behavior, how do those things manifest in this problem? Is there a trigger point? What would trigger that problem? So you can kind of think about the environmental factors a little bit. So you're thinking about that, but you also have things like maintaining processes. What is maintaining this? What is maintaining the problem? What's maintaining the trigger? Is it the thoughts? Is it the emotions? Lots of different ways of considering what's maintaining the issue, because then you can look at tackling that. Core beliefs, you might be able to pick up on some core beliefs. As I said, they're quite deep, quite fundamental beliefs that we have, and it's not very easy always to access. I think for people that are working in mental health, and particularly people that, for me, I can only speak for me as an aspiring clinical psychologist. I'm just so interested in that sort of stuff for me, and really deep reflection, trying to do deep reflection and think about what some of my core beliefs are and think about that sort of thing. But for people that have absolutely no mental health training, like a lot of our clients don't, because they wouldn't need it, that is actually quite difficult. Sometimes people have real issues differentiating between thoughts and emotions. They don't understand the difference. So that can take a bit of practice. So if you're able to pick up on some core beliefs, then that can be helpful. And then you might have something like rules for living. So this is things that we make ourselves do in order to stay safe, for example. So a rule for living I might have is, although this is definitely a rule that I had pre-COVID. It's not so much anymore. I wouldn't go out without makeup on. COVID times, what are you going to do? Of course I'm going to go out without makeup on. But that would be one of my rules for living. So yeah, we have all of these things. As I said, this is really brief about formulation. I highly recommend Emily Barney and Saba and Rachel's webinars. They're brilliant. And Emily Barney's a qualified clinical psychologist, so that's really, really helpful as well. Moving on to the applications of CBT. So as I said, this is a brief introduction. There's so many different ways that CBT has actually been applied. But thinking about different presentations, it could be anxiety stuff, OCD, GAD, generalized anxiety disorder. It could be depression. It could be trauma-focused CBT. So there is a specific form of CBT that's been adapted in a trauma-focused way. So that can be really helpful. Eating disorders, there's different manuals for CBT, because it can be manualized. It can be the idea behind it kind of makes sense and it's logical, and you can write it out and you can manualize it to make it sort of more generalizable. So there are manuals for trauma-focused CBT, for working with OCD, for doing eating disorders. So you can work with lots of different presentations. You can also work at varying intensities. So in lots of services, they will have like low intensity or high intensity workers, for example, or split it up like that. So low intensity often means it could be like a once a week group, or once a week, once a fortnight, once a month meeting with a low intensity worker or something like that. So that could be non-guided or guided self-help, which could be, as I say, worksheets, could be psychoed courses, could be leaflets, could be lots of stuff. Self-help guides, there are lots of those around. Could be group CBT, group therapy. It could be individual CBT. It could be individual once a week. It could be once every 2 weeks. Or high intensity CBT, which is usually like complex cases or trauma focused. So there's various ways, and that is the thing with CBT. It is so broad that it can be applied in lots of different situations. So yeah, those are the applications. Moving on to the strengths of CBT. I think there are quite a few, to be honest. I think it's applicable to various presentations, as I've said, and to varying intensities, as I've sort of said. It can be group or individual, which is really helpful. it's logical. It makes sense. We all have thoughts, we all have emotions, we all have physical sensations, we all have behavior, and it makes sense to us. I mean, it makes sense to me, and I think it does make sense to people. You know, it's not one of those highly academic sort of models that you really need to think about. This kind of makes sense, and it's fairly easy to grasp. It's not got any really complicated language or anything like that. And it's evidence-based, and it's recommended in all the guidelines, basically. The NICE guidelines for loads of different presentations, same as Matrix Cymru and Matrix Scotland, loads and loads and loads for various age groups, for, you know, for children, for older adults, for working age adults, for so many different people. That is a big strength. And it one of the things that I really like is that it provides techniques for future distress. So it provides you with things like thought diaries. It provides you with actual things that you can do, sometimes a bit of mindfulness, actual techniques that people can use if they feel that way again, or if they notice that they're in that sort of way, they, you know, they're going into that sort of down that path again. So that's really good. As I said, it can be manualized, so it can be, you know, we can write down, this is what you do, this is what you say, this is how many sessions it takes, this is the dose that you get, the intensity, that sort of thing, which is really helpful in terms of service delivery. So that's one thing. It's really collaborative. That is the idea. You know, this is not, if you're imagining therapy and you're imagining Freud sat on a chair with someone lying down on a chaise longue, this is not it. This is absolutely not it. This is collaborative with the therapist and the individual on an equal playing field. You know, it's not the therapist that's the expert and the individual that's like, help me. It's equal, and I like that a lot. And I think in my experience, patients, clients respond well to that. I think they quite like that. They're not being spoken down to. They're kind of like, let me help you, you know. It's easy to train staff in the approach. You know, I say easy, but because it's so widespread and because it's so evidence-based, there's so many resources out there to help kind of train staff in this approach. And it can be mixed with other approaches. As I've said, mindfulness, it can have like lots of different approaches in it, which is kind of helpful. So I think there's quite a lot of strengths to CBT, but let's have a little bit of balance. Let's think about some of the limitations. Well, it suggests that psychological distress is intrapersonal and results from unhelpful or harmful cognitive and behavioural styles. So that's lots of long words. So what I mean there is psychological distress is inside us. It is caused by the cogs in our mind kind of not going right and making things really difficult and getting stuck and going down a different way and that sort of thing, rather than looking at the environment that we're in. Yes, it considers a little bit of environment, but it places psychological distress inside the person. If that kind of, I hope that kind of makes sense. It doesn't consider the impact of wider society. So, for example, social constructionist perspective or systemic, you know, you're looking at reality as constructed and that we all operate in these systems. And you actually can't just look at what is inside the person. You need to think about the system that they're operating in, or the reality that is constructed by the language that they use and things like that. So that's, I mean, I do think I'm a massive social constructionist. It's always kind of made sense to me that the language that we use constructs our reality. If you're interested in any videos on those different models, hit me up in the comments and I'll try my best to put something together. The approach is not effective for everyone. You know, yet it is the approach most likely to be offered. So we can only do our best, and it is an evidence-based intervention. Therefore, we are, you know, it's okay to offer it. It is, in fact, that's what we should be offering. But it's not effective for everyone. Some people really just don't get on with it. It doesn't click for them. It doesn't make sense to them. And they might, for example, if you believe, you know, if you are in a family system and your family is really, really important to you, a systemic approach might be a little bit better. But you might not be offered that. So that's slightly an issue. And I think that is different depending on where you work. So I currently work in Wales, where there seems to be, in my experience anyway, of services, there seems to be a far broader range of different psychological models of available in services in Wales than there are in England. In England, you've got the IAPT model, and it's in CBT, which is always what, you know, I've worked in. So it's interesting. It's just something to consider. And there might be more effective approaches available. For example, EMDR. For those of you who don't know about EMDR, I'm absolutely in love with this approach. I mean, we've got people that have got really, really complex trauma, and they have like 3 sessions of EMDR and they feel much better. It's absolutely magical. And again, if you want me to do a video on EMDR, I'm happy to do my best on that. So let me know in the comments. And is it adaptable for individual needs? So by individual needs, I mean for someone with autism, someone who's blind, someone who might have other sensory impairments, those sorts of things. I think it is. You know, it's been proven to be adaptable for older adults. I will put some information in the comments, a link to a guide for CBT for older adults, and I'll put there's I think it's the University of East Anglia has loads of different CBT things that I'll link in the description below. And let me make a note. I'll definitely do that. So yes, I think it is adaptable, but I think we've got to make sure that we are thinking about, if we're going to use a CBT approach, we need to think about how we are adapting it for individual needs. Here are some of the most helpful resources that I could find. There's the NHS website that, you know, gives you a breakdown of CBT. Mind website has loads on there as well. That's there. The Royal College of Psychiatrists website, again, has some stuff on CBT. BABCP website. And here are some books. This is the book to get. This is absolutely the book to get. This is what my the presentation is sort of based on. This is what my core textbook was for my master's, and I'm really glad I bought this, because if I'm going to have a career in mental health, we're all going to be doing CBT, you know, for a while. You know, you are going to have to do some CBT. So investing in that book, if you can, ask for it for Christmas, is definitely what I'd recommend. But there are lots of other ones. You know, cognitive therapy and clinical practice is really helpful as well. And there's Judith Beck's book there, which is CBT Basics and Beyond, which is really, really helpful. Have a little look on Amazon. There's loads on there as well. So thank you so much for watching. I really, really appreciate you taking the time to come and visit my channel. I really appreciate it. Don't forget to check out our other videos, which I will make sure that I will link somewhere. Forget where I put my camera there. And subscribe. Make sure you subscribe, and then you get all the updates. And also you can follow us on all the social medias. We're on Facebook. We are on Instagram. On Instagram, I try and do a couple of posts a week, just keeping it nice and informative. So let me know what you want to see. Let me know what other videos you want to see in the comments. So thank you so much for joining me, and I will see you next time. Bye.